Are you ready to go, Charles? You're on mute. Yep. Good morning, everybody. I'm delighted to invite you to another of our Saturday health hours. And I'm really excited today because we've got three excellent speakers. They are well known to those of you who've joined us for the last few weeks. And I've heard them all speak before, and they're passionate about health inequalities and how to empower us in the Black community to continue to access health and look after ourselves in the best ways we can. So I am going to invite my three colleagues, and our first speaker today will be Dr. Bola Owolabi, who is going to speak and give us an overview of her role from an NHSI, NHEC perspective. She's the Director of Health Inequalities for NHSEI. Our second speaker for the day is going to be Dr. Diana Asante, who is going to give us an overview of long-term conditions. And our final speaker for the day is going to be Dr. Margaret Ikpo, who's going to talk to us about healthy lifestyle and how to get active. They're all GPs, and I think primary care is really, really important. I think a lot of health focuses on secondary care. So when you think about your doctor, you think about your surgeon or somebody who manages your health when you get to a hospital. But really, the primary care is really, really important as a foundation so that we can all get healthy. So without further ado and saying too much, I'm going to hand over to our speakers. As usual, you can put your questions in the chat. I will put your questions to the speakers. You can also have an opportunity to ask direct questions yourself. But I'm looking forward to a really great session to end our April Health Hour. Thank you for joining us, everybody. So Bola, over to you.
Thank you so much, Ngozi, and Charles and the whole CAHN team. Thanks so much for the invitation to spend this Saturday morning with you. I hope my screen will behave itself and share, but I would like to just speak to this deck of slides, if I may. So thank you for the kind introduction. I started in this role on the 4th of January, and I can't believe that it's 4 months already. But as you've just been saying, I practice as a GP, and I've worked in various roles in the NHS over the years, and started as Health Inequalities Director on the 4th of January. I've had the opportunity of talking to lots and lots of individuals, teams, organizations across the country over the last 4 months. And I believe that the vision that I'm about to share with you is a distillation of the voices of many, many people. I'm really pleased because I sensed it growing and developing in my own consciousness as I spoke with people. And I'm delighted to share with you that the vision that we're trying to achieve in the Health Inequalities Improvement Program within NHS England and Improvement, but working with the NHS, working with organizations like CAHN, working with communities, the vision that we're taking forward is how we get to a place where we do deliver exceptional quality healthcare for all. And that is by doing three things: by ensuring that people do have equitable access, and that when they've crossed the threshold, they have an excellent experience, and that we do deliver as optimal an outcome as we can based on the evidence that we have at the time. You know, I labor the point about these three things because I often tell my story, and apologies to those who may have heard it before, but it really is the story that powers this vision. I didn't have any problems 18 years ago when I was in labor with my son, who is now a first-year biomedical science student in Sheffield University. Nobody stopped me from getting onto the labor ward. Nobody stopped me from having access. But the issue was being forgotten in the side ward for hours to labor with no pain relief, with nobody coming in to check whether we were dead or alive, or what progress we were making. It's the experience that was the difference. Experience matters because it impacts on people's outcomes and it impacts on their future health-seeking behavior. And that is why I'm holding my colleagues in the NHS to this vision, that it is about access, it is about experience, and indeed people's outcomes. And what is it that makes it particularly compelling now for us to have this focus? You will all have seen the data, and I've been following CAHN's activities over the last year, your webinars, your publications. You'll all be familiar with the disproportionate impact of the pandemic on our communities. That is one powerful driver, but there's also the drivers that have been there before. You know, the fact that women in the most deprived areas of the country have a significantly lower life expectancy gap, life expectancy compared to the average population. The fact that people living with learning disability also live on average 30 years shorter than the average population. You would have seen the learning from disability mortality review report last year, and the latest one is coming out again soon. We know that people living with severe mental illness, again, they live in the order of 10, 15 years shorter than, the average population. So we have these pre-existing life expectancy gaps, healthy life expectancy gap. In the most deprived areas of the country, there is a 19.6 years life expectancy gap. These are very powerful drivers, and all of the things that we've learned through the course of the pandemic. And I've been pondering on this and reflecting on what is going to be our legacy. We've all lived through and are living through this pandemic. What will be our legacy? And I do believe that our legacy absolutely has to be narrowing health inequalities. Whatever report you refer to, whether that is the Public Health England COVID disparities report published in April last year, or the Beyond the Data report by Professor Kevin Fenton, published in June, July, the 10 years on Marmot review, the CAHN report, which is a condensation of your various webinars. All of those reports tell us and focus us on the fact that we have pre-existing health inequalities and they've not gone away. If anything, they've been exacerbated and accentuated by the pandemic. And so I commend to you this legacy, that it genuinely does need to be about how we are going to harness our collective will to narrow health inequalities. And I think there are three things that we can do. We can set the direction. And I've been saying to my team within NHS England and Improvement, we absolutely have the ability to set the direction. And that's why we've set out the vision that I've just been talking to you about. We can create a positive improvement culture. And that's why I never turn down the opportunity to join conversations like this. Because the way to change culture, the way to shift culture is not just by writing lots and lots of reports. It's by having conversations with people. And so whether that is one-to-one, whether that is in a group like this, whether that is in addressing 250 people, I try to take every opportunity to have this conversation, because I really believe that creating that positive culture of improvement is how we are going to narrow the health inequalities gap. And you shift culture through conversation. And finally, it's the fact that we can deliver with others. I know that my team within NHS England and Improvement, no matter how big that team is, it will never deliver the vision on its own. We have to work in a super matrix with other programs across NHS and England and Improvement, across the NHS, community providers, community action organizations like CAHN and others like you, we have to deliver with others. And in doing that, I think it's important for us to bear something in mind. For all the terrible things that have happened during this pandemic, it's important for us to go forward with an appreciative inquiry mindset. It's very easy to focus on all the things that have gone wrong. It's very easy to be sucked into that deficit way of thinking where all our focus, attention, and energy is invested in the things that are wrong. I want to encourage us this morning to try to think differently. Let's take a different lens. Certain things have worked, and I'll talk about those in a little bit more detail. It is possible for us to turn our gaze from the things that we're missing, from the things that haven't worked, onto the things that have worked and the things that we do have that we can build on. And so I have been proposing and will continue to propose that as we collectively work on this agenda of narrowing health inequalities, let's think about 3 quality improvement methodologies. One is about how we can use data to drive improvement. There's a lot of data. How can we move away from just talking about the data? And we've seen it in the COVID vaccine program. When the data came out in the middle of January, that the uptake rate in the Black African community was 38%, when it was 82% in the white population. Organizations like CAHN and many others like you right around the country got behind the agenda. You put on webinars. I've been on countless webinars, with the Churches Together England, with the faith community, with the community leaders, with the vaccine minister. You've had him on your webinar. It's about using that data to drive improvement. And we've seen the data move. The data has moved through our collective effort and energy. That is the first quality improvement approach that I'm advocating that we should take, using data to drive improvement. The second one is that appreciative inquiry that I've just been talking about. How do we inquire into what is strong and not focus exclusively on what is wrong? How can we build from strength? I now know CAHN. I didn't know you before the pandemic. That is a powerful connection. That is a powerful network. How do we harness those connections, those relationships, those partnerships to take us forward into the next phase? How do we genuinely begin to tap into some of those things to deliver that vision of equitable access, of excellent experience, of optimal outcomes for all people, regardless of their race or creed? And finally, co-production. How do we work with the communities, not as an afterthought, not as a tick box exercise when we've already decided what we're going to do, but actually genuinely, respectfully engage communities in the design, the implementation, and the evaluation of our various programs? How do we genuinely listen with curiosity to hear what people have to say, and not just hear what they have to say, but recognize they have the best ideas about what works? It's their community. They have the most sustainable, creative ideas about what works because they understand the community. The community trusts them. And that's one of my lessons from the pandemic, the power of trust. The messenger is just as important as the message. And so that's why I'm advocating that we do take forward these 3 quality improvement approaches to tackling the challenge of health inequalities. And I will round up with these 2 slides. We've said that the NHS is not able on its own to treat us out of health inequalities. That is true. But the NHS does have a powerful role to play across these 4 domains. The NHS as a commissioner and provider of of services is able to leverage that influence. The NHS as a key partner within integrated care systems, working with local authorities, with voluntary sector, with community action, can make a difference. The NHS as an anchor institution, working because it has buying power, it has employment power, it has the power of the ownership of estates, the NHS as an anchor institution, and finally, the NHS as an employer. We employ 1.4 million people. They are a microcosm of our wider community. If we can narrow health inequalities amongst our own staff, then we do well in narrowing health inequalities in the wider population. And I'll finish on this, the role of the voluntary sector. You know, the powerful advocacy role that you're playing, the insight that you bring, you know, your ability to intervene where we struggle, whether that is in the work you've done in driving up vaccination rate, the work you've done in bringing people onto the organ donation register, the work you've done in terms of sickle cell, the work you've done in terms of blood donation. You have the power of intervention. You're able to reach into the communities deeper than I or my team ever will. You have the power of primary intervention and primary prevention. You know, before people end up in my office as a GP, a lot has happened already in their lives. And actually, the voluntary sector is able to meet people in their communities in that space of intervening early through primary prevention before things go horrendously wrong. And finally, your power of connection. Look at the people on this call today, unpaid, here because we care. And I know that you're having similar conversations beyond the confines of the webinars. And it's about recognizing, I completely recognize the role of the VCSE sector in actually enabling people by giving them purpose and connection. You know, I will always quote Sean Lockwood, previous chief executive of Community Catalyst, who said to me, Bola, purpose and connection enable people to live their best lives. And I know that the voluntary sector is more powerful, more able than any to give people that purpose, that connection to enable them to live their best lives. I look forward to working with you. I know we completely will fail if we don't recognize what you bring and how you can help us to deliver on that vision of equitable access, excellent experience, optimal outcomes for all communities. Thank you so much.
Thank you very much for that, Bola. That was fantastic. And I think you really spoke to us when you said that it's about purpose and connections. So we're very clear about our purpose. We're building connections, and I'm really pleased that we've got a connection with you. So I'm going to hand over to our next speaker. I think what we will do, we'll leave all the questions to the end because I do have some questions already. So we will leave the questions to the end, if that's okay. So I'm going to hand over to Diana Asante, who is a GP in Cambridgeshire, who is going to speak to us about healthcare in primary care.
Hello, thank you very much. Thanks to everyone. And that was really a wonderful presentation, Bola. Thank you so much. And you ended on such a great note, purpose and connection. And so I'm very pleased to be connected to CAHN and all the great work that you're doing and joining the purpose as well that we share to try and spread the education and empower each other and be of help to each other as much as we can. Lovely to see everybody and to speak to you once again. It's always an honor and a pleasure, and I am indeed honored. Charles, can you help me please project those slides? I'm having a bit of a challenge with my computer here. So I'm a GP in Staffordshire, by the way, and this morning I've been asked to talk briefly about the difficulties that people face when they try to access health from a sort of primary care perspective. So as you know, GPs are primary care practitioners or primary care physicians. We are sort of the primary care, or the gate, if you like, into the NHS system. And I know that some things might seem quite basic, but equally some people get confused about what GPs do and how they can access healthcare. And so I was asked to sort of talk briefly about some of the things which pose challenges to people accessing healthcare in the community or the NHS in general, and some of the solutions that we can present to some of these problems. So most of the information helpfully was from the NHS England website in relation to improving access for all. So if you want the sort of in-depth information, you can go there, but this is a bit of a summary if you like. Right, so just before we move into it, who can register with a GP? Because some people are registered with GPs, some people are not. Some people worry about who can register with a GP. Some people, because of their immigration status or whatever reason, they might not have a permanent address, or they might not have an NI, or, you know, whatever reason, they feel that they can't register with a GP. And that can be quite a barrier to people accessing health. I've come across people who need to see a doctor, need to speak to a doctor, or need medication, and they feel as though they have no options. So just very briefly, everyone is entitled to emergency health. Everybody, anywhere, is entitled to emergency health. And that is part of the aim of WHO. How does that translate on the ground? It translates in the sense that if you needed emergency healthcare today, then irrespective of whether you're registered with a GP or not, if you've got central crushing chest pain or acute shortness of breath, you've collapsed, whatever, it doesn't matter your immigration status, it doesn't matter what you have and what you don't have. You are entitled to go to A&E or get the ambulance service and be seen as an emergency. So let's get that clear, because some people are not aware of that, and it can be a barrier to people accessing health. But generally, who can register with a GP? Anybody can register with a GP. I know that when you turn up, the receptionist might ask you for proof of address and a passport and NI and all of that. Actually, we're not obliged to take those things. It's not an obligation that you should provide those things. It's useful because for someone to be able to access free NHS treatment, they should be ordinarily resident in the UK. So ordinarily resident means that you're legally resident here and you have a place where you stay permanently, which can be identifiable, and that is the reason why they would normally ask for your passport or proof of address or proof of ID, etc., to see if you would be entitled to that free NHS treatment. But for the purposes of registering with a GP, anybody can. So anyone who needs medical help from primary care can register with a GP. If you're a temporary resident, say you've gone to visit family for a week, or you've just come for a few days, anything between 1 day and 3 months, you can be registered as a temporary patient. Can be registered as a temporary patient, and you will be given the necessary care that you need within that period. So it might be things like your medication, it might be things like within that period you need to seek medical help, which is sort of relevant to primary care, and that can be addressed at that time for you. Obviously, then they're permanent residents, people who permanently live in the UK or live here long term, they would permanently be registered at a particular practice within their catchment area. And then there's a separate form for people who are overseas visitors who are here for more than 3 months. So anyone can register. The dividing line comes in as to who will be entitled to free treatment and who will not be entitled to free treatment. So moving on, if you're ordinarily resident, then what happens is that you'll be entitled to NHS treatment. And if you're not ordinarily resident, then they might say that you would need to pay, and that is for secondary care treatment. So when you need emergency treatment or urgent treatment from primary care, nobody's going to be charging you. The receptionists are not immigration officers to be checking and asking you things. So just as a background, because a lot of what we're going to be talking about will be based on the premise of people who have the access to health, but there are barriers for them accessing those care or health needs that they should be getting. So moving swiftly on to what are some of the things that pose barriers? What are some of the things that prevent people from accessing the healthcare in primary care? And I've listed about 6 points. I'll try and go through it very briefly because I know because of our time we're limited. So the first thing is recognizing when to seek help. How do you know when to seek help? So some people are not sure. Is this something I should speak to the GP about? Is this something I shouldn't speak to the GP about? Would it be deemed appropriate if I speak now? Do I need to wait for 3 days, wait for a week or not? Do I need to get something from the chemist first? You know, when do I speak to a GP? When do I seek help? And that decision can be a barrier for people accessing help because they're not sure of when to seek help. Sometimes they don't seek help at all because they think actually it's not appropriate. I better not bother them, or they might not want to know about this. If in doubt, seek help. If there's one message for you to take home, if in doubt, seek help, because you're better off seeking help and being told your options or being provided with a solution than not seeking help and finding out down the line that things have gone a bit too late. But through sort of education sessions, seminars like these, posters that we see around, adverts on the TV, people will get information as to when to seek help. For instance, with probably not the best example, but quite a useful one, you know, with things like cancer adverts, they will say, if you've got blood in your urine for a very long time, you must speak to your GP, you know, so someone who is not sure about whether to ignore such a symptom, an advert like that might prompt them to seek help. So recognizing when to seek help can be a barrier. And if you're not sure, ask. If in doubt, seek help. The second thing that can stop people or be a barrier that I've realized or noticed in primary care is deciding whether they should seek help or not. So that's similar to the first one. The first one is actually knowing, is this symptom something I should be seeking help about? But once they've thought, maybe I should, that actual decision can also delay things. So sometimes people are not sure, is the timing appropriate? Have I left it long enough? Or should I try something over the counter first? Would I be allowed to register? So we've talked about that already, that you can register with a GP if you need medical help, or if it's an emergency, you can go to A&E. Would this impact sort of my status? Would this impact my work? Is this going to have an impact on me? Sometimes people have had negative experiences. Bola talked about how people's experience of the healthcare system can shape how they view the healthcare in future. And so it's important, experience of how the experiences that we've had in the past are very, very important. So if someone has had an untoward experience in the past, or they've had a negative experience, it can affect them deciding whether to seek help or not. They might go, actually, the last time things didn't go really well, so I'm not going to bother. So again, that could be a barrier. And so there are options available. You know, pharmacies can be helpful to signpost you, to tell you the sorts of things that you do need to seek help about, or speak to a GP about, or go to A&E about, etc. Care navigators and the surgeries, the GP surgeries can be of help. NHS 111 is basically GP, but mainly out of hours. They provide the out of hours and other services as well. So again, NHS 111 is quite useful. Even friends and family, we have, you know, table conversations with our friends and family, and they tell us about things that they've been through where they had to speak to their doctors or their GPs. And so chatting to someone, they might say, actually, I think you should go and speak to your doctor about this lump in your breast, which you've had for a while. So that is another thing that can be a barrier. The decision as to whether to or whether not to can be a barrier for people seeking help. But those are the ways to navigate those barriers. Now you've decided that, okay, I'm going to seek help. You're actively going to seek help. What are some of the barriers that we face when people actively decide to seek help? So the next slide will show us that when people decide that they actively want to seek help, there are still barriers in the way. So some of the barriers might be not knowing where to go. Is this something that I need to phone my GP about? Is this something I need to phone 111 about? Is this something I need to go to A&E about? So we have patients who turn up to A&E, and A&E says, actually, this is something your GP should be dealing with. We have patients who ring the GP and we say, actually, you probably need to go to A&E for this. And we have patients who ring 111 and they say, oh, why didn't you speak to your GP? And then you go, actually, I've been trying to get through the whole day on the phones and I haven't been able to. And that's why I've come to you. And they say, well, you do need to go back to your GP. So sometimes being unsure of where to go can also be a barrier, or you end up going somewhere and then we get passed from pillar to post. So just as a brief overview, if you are registered with a GP, then basically anything and everything which is not life-threatening, which is not sort of putting you at risk of dying now or very severe that you need to go any, comes through the GP. So you'd make an appointment, try and speak to somebody, or try and have some input from the GP. If it's out of hours, after the GPs have closed, then you ring 111 and the out of hours service would deal with that. If it's an emergency, a very severe situation, someone has collapsed, someone has passed out, a serious accident, they've got crushing chest pain, they think they might be having a stroke, they've got severe breathing trouble, things like that, they go to A&E. Now, as I've said, people who are not registered with GP might feel that they can't access health. We've talked about that already. Even if you're not registered and you need to seek the help, because at that time when you decide to seek help, it's quite key that you carry through with it. Because if you don't and things deteriorate, then you might end up in A&E when actually this could have been dealt with a lot sooner at the primary care level. So that can be another barrier for people sort of trying to seek help when they've decided that actually I'm going to seek help. And then when it comes to appointments as well, these days we know that things have changed a bit because of COVID. So we're doing a lot of remote consultations. There's a lot happening as telephone triage. So when people phone in, you would be put to a phone list first, someone rings you back, speaks to you, and then they decide whether you need to come into the surgery to be seen face to face. Some people can offer video consultations as well, where we can sort of see you on the video and make a judgment, a clinical judgment on the situation. And again, another barrier could be that if people, because of their work timings, struggle to get an appointment, that could be a barrier. So there are extended access services. There are GP services that are working late and running late till about 8 p.m. There are extended access services. There's services running at the weekends as well. And you've got 111, you've got the out of hours. So let's not let that be a barrier as well. And I know that sometimes, depending on where the location is, we might struggle to get to those places. If it's deemed necessary, home visits can be arranged as well. And there are resources and facilities in place for the right people to get home visits as well. So that is another common barrier. The fifth barrier is physically getting there. It could be transport related issues, childcare related issues. I come across a lot of patients who say, I've got to leave my kids with somebody and so I can't get there. What do I do? I've got a lot of people who say that, you know, I don't speak very good English. Ask for an interpreter. There are interpreter services available. At the time of booking your appointment, ask for an interpreter so that will be factored into the consultation. And there's an interpreter line for any language under the sun. And cultural issues can be a barrier as well. People with disabilities, people with autism, visually impaired patients might need a specific time of the day appointment. They might need longer appointments. Let's discuss all these things at the time of booking. I know that sometimes we feel as though we're being a burden, and so we don't want to cause any trouble. But actually, if you don't give out this kind of information, you don't quite get the right or the suitable appointment for you. You might end up with a 10-minute appointment, which is the standard thing that we would offer everyone. But if you probably need something slightly longer because you're visually impaired or you've got some challenges or you need a translator, it needs to be factored in so that we can provide people the right kind of help. So again, those are the sorts of things that pose barriers, but that's how we can navigate them. And then I think the final point I was going to touch on was obviously the communication issues, which I've talked about, getting the interpreter and things like that. So those are some of the common problems that we find in primary care, which present barriers to people accessing health. From people from our background, the sort of Black or Caribbean or minority ethnic background, I know that language can sometimes be a challenge. Language can be a challenge. Having confidence in the healthcare system can be a challenge. Not trusting the system can be a challenge as well. And that is why when we have these sorts of discussions, we're able to educate each other. We're able to sort of signpost people in the right direction. We should never feel as if that help isn't available. There is help available, but we need to try and access that help. And even when we feel that we've been turned back, let's not give up. Let's keep trying. I always say that our Caucasian counterparts, they will keep seeking help. They will keep ringing about the same problem until they get help. They will keep knocking on your door until they get what they want. but we feel as if we're a bother to people, and so we tend not to, and we give up easily, or we suffer in silence, or quietly we sort of struggle on with our conditions that are sort of posing challenges to us. So that's really briefly. I think Margaret is going to speak a bit about a similar sort of topic. So briefly, that is my submission on some of the barriers that we have encountered, or we see commonly, for why people have difficulty accessing health. And in groups like this, let's continue to see how best we can empower each other and empower our community with the right levels of information to access help. I think we'll be speaking about obesity at some point, but I'll let Margaret do her portion, and then if we need to come back to that bit, we'll come back to it. So thank you for now, and at the question session, we'll address the questions. Over to you, Ngozi. Thank you.
Thank you very much, Diana. That was really interesting as well. I think one of the things that was key was when you say don't give up, because that happens quite a lot. You're fobbed off and you think, well, I'm not going to go back. But I think we can discuss a bit more when we have specific questions after Margaret has spoken. So thanks very much. That was another excellent talk. So I'm now going to hand over to Margaret, who again is not a stranger to CAHN. She's been here before, and she's a GP in Hull. So thank you, Margaret, and I'll hand over to you.
Thanks, Ngozi, and thank you for having me back. Are you right just to give me a thumbs up that you can see the screen? Because thank you. Thank you. So I'm Margaret. I'm a GP in, I call it the Far East, otherwise known as Hull. We are a very active practice where I work in an area called Holderness, but possibly one of the most deprived areas in the country. I think at one point in November we had the highest rates of COVID in the country. We serve quite an underserved population along the coast, and sometimes people think, well, because you live near the coast, you're quite well to do, but it's not the situation in the east. It might be in the south of the country, but definitely not in the east. We have high levels of chronic disease, so diabetes and lung disorders in particular. So I do a lot of things. Call me jack of all trades, perhaps. I like teaching students and tutors. I dabble in a bit of research, primary care research, and I also chair a faculty for the Royal College. So what I'm essentially going to do, without duplicating too much, is focus on why I think we're here. And then I'll talk a little bit on the Get Active scheme that has just been launched. And I'll talk a little bit about how we can maybe be a little bit more inclusive in what we do. So these are my thoughts, and some have already been discussed quite eloquently by Bola and also by Diana with regards to access. So we do have a lot of social reasons, which I won't go into too much. So perhaps our values, our environments as well, personal reasons why we don't get involved, and maybe some even cultural reasons. And in terms of Diana mentioned obesity, and I was thinking of an aunt of mine who had done so well. She'd seen her GP and she was prescribed some tablets. It was a tablet to decrease fat absorption, to lose weight, and she lost about 4 stone and she looked amazing. But then her core church prayer group said to her that you look unwell, Irene, you're not looking very well, because in some cultures being bigger is associated with being well. And so unfortunately she ended up putting all the weight back on and developed all sorts of things, which was quite sad, really. So lots of different reasons. It could even be religious reasons. There are some genetic reasons. So we know particularly in Southeast Asian cultures, a lot of them are prone to diabetes. In Afro-Caribbean cultures, some of us are more prone to developing things like hypertension. And of course, we have environmental factors, things we can control. So what we do with our waste, etc., and how we try and reduce our carbon footprint, and things we can't control. So some of you might remember this young girl that died, Ella Kissa-Deborah, age 9, who died in London, but was one of the first cases to have pollution recognised as a cause for her death. So those are things to take into account. So the social, environmental things and genetic things account for about 50% of perhaps the inequalities. So don't shoot me down, because the rest of it, 40 to 50%, is essentially how we behave ourselves with regards to our diet, smoking, sexual activities and physical activities. So just before this webinar, someone sent me this video. Some of you might be familiar with Maccabee, and I just want to play it because it's less than a minute. So I hope I'll just share my sound on here.
Greetings. Cut down on sugar. If you coulda, then you shoulda. If I were you, I woulda. Cut down on sugar. If you coulda, then you shoulda. If I were you, I woulda. Sure. Too much sugar, people I eat. People like it because it is sweet. A lot of people think it's a treat. You think it's a treat? Ask your teeth. Cut down or try cut it out. The processed sugar I am talking about messes up your system without a doubt. Too much sugar going into your mouth, said to be addictive, your brain's activated. Many diseases it is implicated. To your taste buds, very seductive. Added sugar can be destructive, linked to obesity, then diabetes, inflammation, heart diseases. To the youths, they make it attractive. I've seen it make children hyperactive. Cut down, I dare you to risk it. Whole fruit instead of the biscuit. Fruits got sugar, yes, but it's holistic. Fiber and nutrients, more realistic. Cut down if you are able. A lot of added sugar in the things. Read the label. It's for the shelf life, also the flavor. Under hidden names, gotta be a translator. Cut down. Do yourself a favor. Change your habits. Change your behavior. Remember, you are your own savior. Do your research. Could be a lifesaver. A Maccabee Medical Monday. Yes, I am.
So I showed this to the kids and they're like, oh yeah, we know Maccabee. And, you know, I was like, okay, clearly I'm not down with the kids anymore. But I felt that message for me was a lot more impactful than some of the stuff that I see that comes through even our own organisations, I must say. In that minute, you know, my daughter was already saying, well, perhaps, Mummy, we shouldn't use sugar at all. So, oh, sorry, I'll put the next slide. So this is the Get Active slide. So the website's on the left. And there's lots of useful tips on this website for people that are keen to become more active. And so you might have heard of the Couch to 5K program. There's better leisure centres and lots of tips on what's good to eat and what's not good to eat. So it's really, really useful. However, so I've been a GP for about 20 years now, and I've seen these programs come and go. Yet one thing that is certain is that we are still increasingly become an overweight and obese nation. So, and I put myself in that category as well, unfortunately. You know, 60% of us need to lose weight. But why has it been so hard, despite all these programs that we have, to tackle this, particularly this disparity between us? Why are we still heading in the wrong direction? And it's difficult. There's no single answer. There's lots of different things. The first thing I could think of was life, essentially. Life gets in the way. We all get busy. And particularly, I find as a woman, I've found it successively harder the more children I've had. It feels like my metabolism is just not what it was when I was a 20-year-old. So I think it's really important. Bola talked about inclusivity, being inclusive. I think it's important that we are able to find ourselves in supportive environments and seek out our personal motivators. What is your why? And I think as a general practitioner, that's the first thing I tend to try and do with my patients. You know, it's easy for me to give you a prescription. It's easy for me to signpost you to a leisure centre. But actually, what's your personal motivator? I had a boot camp class this morning at 7 o'clock in the morning. And on a Saturday, it's not something 6 months I would have ever thought I would be doing. So my why was my cousin, same age as me, 45, died in London last year with COVID. And at that point, you start to really evaluate what is it that we need to do. There's only so much, I guess, I can do as a healthcare professional for my patients, but what is it that we are trying to do ourselves? There's been a change in dynamic, I think, over the years, where we've gone from being quite paternalistic as GPs. Our patients now are very much informed, and so quite rightly, through various outlets, whether it's the internet or just the information that they read. So often we try to approach a consultation in what we call a shared way. So we're making decisions together. So that's one of the first questions I ask my patients. Why is it that you want to do this? And what do you think is the best way you think I can help you? Because there'll be things that you know, but there'll also be things that you don't know. And also, I think there needs to be, I find a lot of people still don't understand that the GP Unfortunately, at one point in time, a few years ago, we didn't have enough GPs. So the role of the GP has become quite diversified. So we have quite a multidisciplinary team, which is made up of different individuals, so social prescribers, people like paramedics even work from our practice. We've got respiratory nurses, so different people we can signpost people to. But it comes back to Diana's point about access. You don't know what you don't know, so we need to become more culturally aware in how we deliver these messages to our patients, so they actually know that actually I don't need to see the GP for this condition because my knee hurts, but they've got a physio on site. The physio may be the best person to see me because our physio can prescribe, our physio can request a scan if needs be. So I think it's really important that we try and get these messages through. So when it comes to getting active, I've just 4 tips. Think of your why. If you were on CAHN, I think you did a talk with Jonathan Makanjuola, the consultant urologist recently, and he had a wonderful analogy about treating your body like a Porsche for men. And I think that's what I think of. Your body is your most prized asset. So when we go back to Maccabee's talk, cut down the sugar, think of what you're putting in. And, our cultures, it's particularly one of my parents is Nigerian, and a lot of the activities centre around food. It's not an event if there's no food involved, basically. But it doesn't mean that we can't make the right choices. In our practice, for example, there's always a tin of biscuits somewhere, particularly during this COVID vaccination clinics when people are getting tired and run down. And I said to them, why can't we just have a bowl of fruit? And everyone just kind of looked at me like, oh, here she goes again. But, it's just making those small adjustments, because there are some people in the practice that are really trying to start small. So start small, but just start somewhere. My own mother, she's 75, and she was struggling to walk. So we got her a small one of those where you sit down on like a seated bicycle. And with time, that built up her leg strength. And now she can walk a couple of miles. So it's just starting somewhere. But don't go it alone. Again, be inclusive. Think of the people that you can have around you to help you, whether it's your family, your friends, your work colleagues. Let them know that actually, I'm sorry, I can't have that because I've got things that I need to sort out. It's not going to happen overnight, as we know. It will take some time for you to get there. So the last bit, I must keep a check on time because I can talk, is about getting involved. I think Bola mentioned about data initially, data to drive improvement. Now, several of us have been on several platforms in the last few months talking about getting involved in terms of being vaccinated. And one of the common things that comes up was how many Black people were involved in these trials? And when you look across particularly the Moderna and the Pfizer trials in America, it was about 10% involvement. And that probably drops to about 5% with their AstraZeneca vaccine here. So my question, I guess, to the audience here is, it's quite difficult because the data that comes from trials allows us to know how a disease works in a particular community. There are historical reasons, which I think I might have discussed before, why we're reluctant, and that I put myself in that category initially as well, and why we are reluctant to get involved in trials. And trials doesn't necessarily mean that you're going to have something medical done to you. There's several different types of trials you can get involved in where people just want your opinion. And the opinion matters. I'll give you an example. Last week we had a trial that's just open to recruitment called the COM-COV trial. So it's for patients or for anybody of us that have had the first vaccine only. They want to try you with a different vaccine. So when you get your second vaccine, it will be different to whatever you had the first time round. And we had 24 hours notice to try and recruit as many people as we could from the Black community in 3 days. And I went back to the National Institute for Health Research and I said, this isn't going to work because you haven't engaged the community to start with when you were designing this trial. Where are my people in the decision making when it came to delivering this trial? You can't expect us just to now go and say, come and, it was very, you're opening us to having very difficult discussions with the community. So it's just to give you just some insight into thinking about how we can get involved in trials. Another thing that tends to come up quite a bit is herbs. I know Charles mentioned this previously. can a remedy of a particular herb help condition? And again, it's quite a challenging question to ask, because most medics, in fact, only less than 10% of medics have any expertise in alternative medicine. Now, that's not to say it doesn't work, because there are common things we prescribe for different conditions, whether it's the menopause or even depression, and we don't prescribe them, but you can buy things over the counter to help that. So, for example, St. John's wort for depression. So it's really important that you do tell your GP if you are on something from over the counter, because sometimes there could be an interaction with any prescribed medication. So that's a really important factor. And also, my mum, again, I keep referencing my mum, because she's a big fan on things like turmeric or moringa, and we have various conversations. So, and I don't discount them at all. But unless, again, we get involved in any particular trials about these, then how will we know that they are effective at all? So that's just something for you to consider. Now, I found some useful resources. Now, despite where we are, because we have a high level of obesity, I can't refer any of my patients into what I call a tier 3 weight management service, but in Manchester you can. So if your body mass index, and that's another controversial thing, but if your body mass index is over 27.5, the Manchester Foundation Trust, particularly if you're from the Black community, will see you, but you need to see your GP for that, to a tier 3 service where you'll have a team of people, dietitians, physios, psychologists, because I think the psychology of eating and why we do what we do is very, very important. And morelife.co.uk, that's another Manchester initiative. If you have a slightly higher BMI of more than 30, and you can self-refer into that service. And then I've just put a few references there because my family like Nigerian food, and I need to find healthier alternatives. And so that's my go-to website, because she does a lot of things there. So really, what I'm going to leave you with is this: get active, because if not you, then who? And if not now, then when? So thank you very much for having me. Back to you, Ngozi.
That was excellent, Margaret. Thank you so much. We've had a really engaging morning from our 3 speakers, and I do have a number of questions. Elizabeth, can you highlight all our speakers? Thank you. So the first question is I've got here is for Bola, and I think someone's asking that although we shouldn't be deficit focused, that the impact of finances on some of our programs is really important. So when you have communities that are underfunded, it's difficult for them to have good access to health. So one example is sickle cell. When you compare the funding of sickle cell and cystic fibrosis, for example, the amount of money that's been put into CF as compared to cystic fibrosis, as compared to sickle cell, means that it's difficult to achieve good research, good outcomes. And in your role as a Director of Health and Inequalities, is this something that is in your purview? I'm sure it is.
Thank you, Ngozi, and to the person who flagged that question. So, taking a strengths-based approach doesn't mean sticking our head in the sand and saying all is well when it's not, but it drives how we have the conversation. So I'll give you an example, and I'll come back to that specific question. When people talk about, having diverse boards, for example, and how important it is to have people from different ethnic minority communities on boards, oftentimes the conversation is had from the point of view of how awful and dreadful and terrible it is that the boards are not more representative and reflective of their communities. But I often say to people, try and have a conversation that says, there is a lot of evidence that tells you that organizations are more productive, they're more effective, they're more efficient when they have diverse boards, not because of the color of the people on the board, but because of the diversity of thought and the diversity of experience that they bring. And I flag places like Google and Microsoft and so on, who have demonstrably proven the point So going back to your specific question around sickle cell disease, I think it's about framing the conversation about the contribution that people are able to make because of extended life expectancy and healthy life expectancy if we invest appropriately into those disease conditions. The fact that people are much less likely then to turn up in crisis, they're therefore much less likely to require unscheduled hospital admissions. It's kind of reframing the conversation in that sort of way in terms of the benefit to the individual and the benefit to the system. I find that that actually energizes people a lot more. I find that that energizes people a lot more than a deficit-based conversation that almost says what you're doing is unfair. What that does is it activates a set of emotions that puts people on the defensive, and people don't have to say it out loud that they're on the defensive. It's a psychological trigger. And then you find that people put their barriers up and you don't get very far. But if it's more of a conversation about the value added for doing something, that energizes people. So it's not denying that there is an issue, it's reframing how we have the conversation.
I think that's a very important lesson for all of us, because I've seen it myself. And one of the things I observed as well was that when I was looking at the workforce race equality scheme scores for different trusts, I found that the trusts that had better RES scores had better CQC results. Just an observation. So there's another question here, and I think anybody can answer it, but it's about how we get ethnicity better recorded so that we can make sure that we're addressing, we have the available data, because data does drive everything. And I think this person who's asked the question feels that there isn't good recording of ethnicity generally. It was to Diana, but anybody can answer.
I'm happy to start, Diana, if that will help. So you may have seen the NHS operational planning guidance that was published on the 25th of March this year. And my team and I worked incredibly hard to write health inequalities across that document. And we've set out 5 key priorities for tackling health inequalities. And one of them is ensuring that our data sets are timely and complete. And we're asking that ethnicity data must be recorded in primary care, in A&E, in specialized commissioning, in mental health, and in community services. So now we have a guidance that is mandating the NHS to take action on ethnicity recording. And because we've identified it as one of our 5 key priorities within the planning guidance that the NHS is going to be working to, it gives me great confidence that we will see progress in this dimension. I just thought it might be useful to feed that in before Diana comes in.
Thanks, Bola. I'm not going to add too much to that, but
You've gone on to mute, Diane. Diana, you're on mute.
Recording of ethnicity, even in the patient's notes, it's one of the things that tends to flag up on that little box on the side. It hasn't been completed. I think back to what Bola was saying, if we have a positive outlook to things rather than a negative, sometimes we do get offended, don't we, when people ask about our ethnicity. And so we don't actually give them information. So I think that is part of the problem, that we ourselves or anybody at all can get offended sometimes for the wrong reasons when they get asked, oh, so which ethnic category should we put you in? Or would you prefer not to say? And some people go, I prefer not to say. And then it moves on. If we look at it from a positive point of view, that getting the right information on ethnicity therefore helps to factor that information into how we can minimize these inequalities, into how we can be fairly represented, we will see it as an opportunity to give that useful information. It's almost as important as your age or your sex or, you know, your other medical conditions, because there are certain medications which might work better. Even when we're choosing antihypertensives, we know that in people from certain backgrounds, a particular kind of medication for blood pressure would be better. So just to add to what Bola has said, let's be more willing to give out our ethnicity. And also, if we are not sure, let us ask the question. So sometimes I pose the question and you're thinking, what are the categories? Which one do I tick? just ask, what are the options? Can you talk me through the options? And let me see where I can fit myself suitably. And I think that with that, we can gather a bit more data. But let's just see the positive side of it, that it's important that unless we've got the right data, the inequalities will continue to exist. Thank you.
Margaret, you've got your hand up.
Yeah, it's just to build up on that. I'm going to just, Bola, if you don't mind, read out what you've just put, because it's coming to that. If your data is not collected, you are not in the room. If you're not in the room, you'll be passed over. This is what Bola's just put in. And I can't emphasize that point enough. If we don't, and it comes back to getting involved. You might remember early on, there was a report, a Household UK survey, that reported that Black people were 80% not willing to take the vaccine. And this was fed through to government agencies. But when you read the report of this household survey, there were about 12,000 respondents. And of those respondents, there were only 191 Black people represented in that report. So that was not, for me, a true representation of the sentiment nationally. So that was my first point. And then coming back to Ngozi's point about res scores and CQC outcomes, myself and a colleague, Sonali Kinra, have recently just put a motion through council which was approved, because our CQC, which is the agency that monitors healthcare institutions, particularly when it comes to primary care, we felt there was a disparity in those practices that are being given inadequate ratings or being closed. But the problem was they weren't collecting the ethnicity data of these GPs. So hopefully now that's going to be addressed. But I can't emphasize this point enough that yes, coming back again, I keep stealing all of Bola's great quotes, sorry. Data does matter. It really does. Thank you.
No, that's really important, that, if we don't have the data, we can't make any changes. Someone's asked a question here about, do you agree, Margaret, and to you, that there's an impact of racism, generational trauma, PTSD, as a barrier to changing behaviours that can improve health?
How much time have you got? Yes, is the short answer. As you all know, the recent government report was very disheartening to read. I mean, it's honestly, where do you start? We have a Professor David Williams, some Williams that you might be familiar with. He talks about biological weathering. So all the things that we've been through, whether it's Windrush, or Pfizer injustices in West Africa, or Tuskegee, or, so many references now, haven't we? Even just looking at how we measure oxygen levels with a device we call a pulse oximeter. There's evidence now that's come out to say that it's not, in some cases in black skin, we need to be thinking about how we collate this data. And that's a report that was done by, and I forget her name, which is terrible, but she's the chair of Melanin Medics. She's a medical student who's just recently qualified, Owolabi. And so I think it's really important that we recognise the impact of structural generational racism and where we are today. We absorb it, but we need the energy to carry us through to say, right, okay, this has happened. What are we going to now do to change the narrative and make sure that these injustices do not continue? And, we talk about the power of collective, which has again been mentioned. And for the first time in my generation, because these things happened to my parents and it happened to my grandparents, and it just seems like an endless cycle. When's it going to stop? It will stop. I'm sure of that, because I think I'm feeling an energy now that I've never felt in my lifetime. So hopefully, and particularly with CAHN, I mean, you've been phenomenal in what you've done. Your reach has gone far beyond the boundaries of Manchester. And I think that's something that you should all be very proud of. And it's with organisations like this and us coming together and talking together that we can hopefully make a difference.
Thanks very much, Margaret. I'm going to try and go through as many questions as I can. One of the things that somebody's asked about is about taboo subjects. So even talking about your addictions within the Black community is quite difficult. So the person who's put this question has said that she's a member of a group called People of Colour Overeaters Anonymous that meets weekly to talk about recovering from overeating and other food disorders. But it was just a general comment, I think, a question about how we overcome taboo subjects. So People will hide things like their smoking, and even sharing their concerns about maybe their illnesses, because sometimes, as you said, Dan, you pointed out about when you're with a group of Black women that talk about their, say I've got a lump, and someone can advise them to go and do something. Now, if you're not happy to share your problems and your concerns, then it's more difficult to signpost people to the right services. So that was just a comment from somebody on how we support people to overcome this. Another comment I've had is that you know that you have a physiotherapist in your GP, that in your practice, that can see people who have knee pain. We don't know that. I'm a doctor, and it's amazing that I found all these sessions really useful. The last time I did adult medicine was in medical school, well, house jobs, which was a long time ago. So all these sessions, I found it very useful for me, but I'm a doctor and I'm not aware of this. So how do I expect our communities to be aware of some of these things? Things like knowing that you can go to your GP. I avoid going to the GP because I always think I'm going to be a bother unless it's something serious. I don't tend to go. And I think many people have that option, because what you hear is the GPs are overburdened, they're really busy. And so you don't want to access because of that. That's another thing that can happen. So how do you find out? How you spread the word, really? I think this is one opportunity to do that. But how do we really spread the word to our communities about access and who to access and how to access? Because tiny problems become big problems if you don't sort them out.
Yeah. Thank you. I'll just make a quick start on that, if you don't mind. So that's really true. And we tend to use the word GP, GP, GP. So in some ways, we give people the impression that we're talking about the GP as the doctor GP, but we're referring to GP as the practice. And so the practice, as Margaret said, has a lot of other professionals these days. It's a multidisciplinary team, and we network with other teams. And sometimes you have a group of practices coming together under an umbrella of a network or a federation, or, you know, a group that provides a lot more services than one particular GP practice would. So very quickly, to answer the question briefly, how else, apart from sessions like these, which CAHN is really doing well on, you can go to the website, look at the practice website. I know that some of the practice websites are not up to date and not great, but take some time, because you'll probably get a lot more information than you think you will. It tells you about who the doctors are at the practice, who the nurses are, who the physios are, who the signposters are, the wellbeing practitioners. It tells you the services that they offer. So just go to the website, look for that information on there. It will tell you about it. The NHS website is quite useful as well. So those will be the two things. I mean, of course, educational sessions, putting information out there and talking about these things. But a lot of people don't bother to look at the website. The first thing is to pick the phone up and try and get through. And I know that that can be really frustrating, because I have tried to get through my own GP, and you know, it's a non-starter. So I know it's difficult. But if you go on the website, there's a lot of information there. You can email these days. You can do online communication these days. So you can send an email and we will get back to you within a certain number of days. Please don't email about things that you really need to see someone about today, because they may not get picked up for a few days. But there are other ways of getting information. And so that will be the way to find out. Thank you. I'll pass it over to the other ladies.
Bola, would you like to pick up?
Yes, thank you. Absolutely right, Diana. One of the other things that we've been talking about, and thank you, CAHN, I can see you've dropped the link to the operational planning guidance in the chat box. I do commend it to you all. Is one of the 5 priorities we've set out is to mitigate against digital exclusion. And that is because I recognize that there are swathes of our community who simply can't afford the devices. And even if they do have the devices, they can't afford the data. And even if they can afford the data, connection becomes an issue, and privacy, etc. And therefore, I think there are some creative and innovative things that we need to think about in terms of how we really reach deep into the community. There's a brilliant program in Bradford where they've trained the barbers to deliver diabetes messages. The men will go and have their hair cut, almost as a matter of fact, they will. They've also trained the imams, and they're able to, through their Friday sermons and so on, just gently thread in the message in a way that is almost imperceptible, but actually very powerful. And what I think we could really work on is what are those other ways, whether it's through our faith leaders, our community leaders, those people who are part of the fabric of the community, the trusted voices. Because I always say that the messenger is just as important as the message. And I think particularly for our community, if we can begin to think, okay, who are those people in the community that people will go to? Who are the people they'll listen to? And they're usually not the most obvious, actually. You know, it's the hairdresser for a lot of people. The number of people who will unburden to their hairdresser stuff that they can't tell anybody else. But suddenly, I don't know what it is. Maybe it's just the fact of feeling pampered and you're just in that relaxed mode and you just start talking. How about if we empower the hairdressers and say, here are some particular issues for our ladies. You know, can you find a way of threading it into your conversation where they start nattering about the food they prepared last night or something like that? And genuinely, I really think there's an untapped, powerful resource in there. We just need to think about it and go after it, I think.
Yeah, I think it's just having the thoughts. So that's a really a good thought, and we will look into that. I'm just going to bring Vanessa in because she has a question to ask.
I think well, good afternoon to everyone, and thank you for your presentations. They're fantastic, really informative and thought-provoking. I just wanted to pick up on a point of diversity being at the table. At this stage, I'd still think it's incredibly important because we're not there yet. That's the future where it won't matter what your race is. But right now, we focus on data, and part of our data sets is looking at friends and family test, the patient experience. How can those at the top understand the experience of patients from BAME backgrounds if they're not hearing their stories? So what we do at MFT is, you know, feed in a patient story. And if you were a person of colour, for instance, sickle cell, we can focus on that because that mainly affects Black and African people. If somebody of colour is at that table, they're likely to understand a bit better the experiences. And if they can share a patient story, then the board or whatever team you're sitting with will get a greater understanding of what it's like to be somebody in sickle cell crisis. Because I've worked across several organisations, and one where the population was predominantly white, and then we had a patient come through ED in crisis, and people didn't know how to treat them. And that's in, the 21st century. So we're not quite there yet. And I think it's important to feed in the lived experience, the patient experience as part of the data sets. And then we can improve the NHS in its entirety. So it's just mainly just to pick up on that point, that diversity is really important at the top, middle and bottom.
Thank you very much, Vanessa, for your comments. Thank you. There's another question about access for difficult circumstances. So you have, for an example, a woman who's pregnant and seeking asylum who doesn't have secure immigration status. She can expect to be charged up to about £7,000 for having her baby, and in the event of any complications, it's even more. So people like this will not access early on, so they don't book early, they leave, they don't have their complications treated, and given the disproportionate levels of poorer outcomes in our maternity care for Black women especially, is there any way, are there any programs about addressing this disproportionality, especially in this group?
That's a really important question, Ngozi, and I'm glad that person has asked. I will like them to please email me and I'm going to put my email in the chat box, because I'm working with the Chief Midwifery Officer for England, Professor Jackie Dunkley-Bent, and her team on the issue of maternal mortality in Black African women. And this is such an important pointer. So if I drop my email, if that individual can please email me, and I'll feed that into the conversation that we're having. Thank you, really important.
Yeah, it's very important. And I know that, just an insight, every 2 years, I don't know if any of you have heard of Embrace, which is the body that looks at outcomes for different conditions in pregnancy. The next Embrace report is going to be focusing specifically on the outcomes of Black women. And that's going to be running from the end of this year, from now until the end of the year. And the report is expected to come out in 2022. So I felt that was a really important piece of work, and Jacqueline's involved in that, as am I.
There's also the 5 Times More campaign. They've just launched their national survey this week, I think, in fact. So if I can find the link in time, I'll try and post it on the chat. The Royal College has also reached out to, of GPs, have reached out to the Royal College of Obstetricians, and hopefully we'll be working together as well on this issue, because as GPs, we are involved in antenatal care and have a huge influence really on outcomes as well. So that's just, I thought I'd just throw that in there. So Bola, you might be getting another email from me about that.
Wonderful, great.
That's great, because when we met for the Embrace topic expert group, there were no GPs, and we did point out that perhaps it would be good to have a GP on the panel, because most pregnancies start off not in secondary care but in GP practices. Okay, so there don't seem to be any further questions, but what I wanted to do was to bring in, is it Charles? Or is it? So I'm going to bring in Alice Ojwang, who is a nutritionist, who's going to give us a nutritional aspect of keeping healthy. Alice, are you here?
Yes, I am here. Thank you very much. Do I have, am I able to share my slides? Yes, I can. Yep.
Okay. Alice, I can just say that we do have about...
Okay, thank you for this.
Alice? Hello, can you hear me?
I can hear you, yeah?
I'm just saying that you have about 5 minutes to go. I can see you've got 23 slides. I'm hoping you're not sharing all of them.
No. Don't worry about that. Yeah, I've been around for a while. I was told 10 minutes though, but if you want me to do in 5 minutes, I will try. Okay, so it's nice to be with you. It was really nice to hear all the ladies talking about health. And yeah, it's a pleasure to be here. I work with Sahara Nutrition, who is a group of dietitians and health professionals working together with the Black community to improve their health. So today I'm just going to talk about a new idea that we want to implement. We've been doing some nutrition sessions for CAHN on Tuesdays, and we have something in mind that can help. And what question am I answering today? I really like what Dr. Bola said earlier. You know, we have to think differently. And definitely, we know we have to engage the community. And so this is the question we're going to answer with our suggestion. In the COVID pandemic era, we have to invest in prevention. Yes, this morning we've talked about, we are really concerned about our people, you know, there's inequalities. But if prevention is not going to be on top of the list, we are still not going to get anywhere. And we know that diet is the largest risk factor for disease and health. And it is really, I mean, we need to spend more time talking about diet. We cannot be giving the dietitian 5 minutes and the doctors had 1 hour, 30 minutes. You know, we need to change that. But today is different. So what am I talking about? So we actually want to share group wellness workshop series that are focused on promoting healthy lifestyles in the community. Group programs these are interactive and engaging workshops which equips the community. We provide information, tips, and strategies and skills needed to change behaviors and make healthy choices in the areas of nutrition, sleep, exercise, and stress management, and even disease management. The group wellness workshops, we use universal learning principles. We use case studies and best practices to deliver practical information. So how long does this sessions take? They take like 90 minutes, and it's really group sessions, and I'm going to give you more as we go on. So how do we recruit people who work in a group? It literally means we are with 20 people in a group or 1.5 hours talking about what their health issue is. So we use data, like for CAHN, we've sent out a questionnaire. Once we get the results, we're going to be able to decide the type of group support, nutrition group support you will have. And so we spell out the requirements, and it is on voluntary basis. It reminds me when I started my practice, a lot, you force patients, do this, but when I learned about the stages of change, then we know that you cannot force people to do something about their health. So when they join the party, they're going to be successful. The support group consists of course, the 20 the participants plus registered dietitians. Sometimes we invite a medical doctor, and then we also have success stories, people who've been there before. So examples of wellness groups that I have worked with for the last 20 years: weight management, diabetes management, healthy you, infant and young child feeding, and digestive health. These are very common. Also, some friends of mine, they run something on mental health and many other topics that they are specialized in. So I'll give you an example of what happens in eating and living well with diabetes group. So we discussed the myths and truths about diabetes, how food affects your blood sugar, dietary tricks to lower your blood sugar and HbA1c and blood pressure as well as cholesterol, how to monitor and manage blood sugar levels, how to prevent complications like lab damage. Just like doctors and nurses have diabetes educator, I am also a certified diabetes educator. And so I am authorized to talk with diabetic patients. And we talk about physiological and emotional changes in diabetes, what to do when you're sick, diabetes medications, and of course, many other topics. And then we have another one that is called Healthy You. Healthy You is a 6-week online lifestyle program that helps people achieve better health and wellness through good food choices, increased physical activity, feeling better about yourself, and understanding nutrition information, know your nutrient, vitamins, and minerals, make good decisions when dining out or eating away from home, how to read and understand labels. These are usually, Healthy You is usually a group when you still don't know what people's needs are and you have a community that wants to learn about nutrition. So you put them in a group, and once you know what everybody's issues are, then you put them in specific groups that is going to benefit them a lot more. So what is the success of the wellness groups? When people get there, when they're ready to take action, they will take action. In fact, what I do with some of these groups, there are some people who are in the group, but they're not participating. I will talk to them on the side and I will tell them, when you're ready, we will be here. But for now, you're not ready. And I realize when I kick out some people from the group, then they get motivated and then they get, but voluntary. And so when you're with you like an adult and we work with you. Of course, dynamics are beneficial, like positive deviance. People learn from each other. And you find that sometimes you let themselves, you find a diabetic patient saying what they have done for them to be able to be successful. Several success stories. So I would just like to say, genes load the gun, but lifestyle pulls the trigger. If a diabetic patient, a mother who is pregnant, and all those situations you can imagine in health, if they don't change their lifestyle, if they're not empowered and engaged to do something about their lifestyle, then the success stories are going to be low. But if we engage them and empower them to manage their lifestyle, then we will be very successful. Thank you very much. I rest my case.
Thank you very much. Thank you. Thank you. So we've had a morning of fantastic speakers. I'm just going to invite Bola and Diane and Margaret to give us a last word on what they feel our take-home messages should be today for health inequalities. Because I think we've said quite a lot, but I want us to have one message from each of you of what we should take home. Bola, I can start with you.
Thank you. So just to say thank you again for the invitation. I've thoroughly enjoyed being on the forum today and really looking forward to connecting offline. Actually, I think we have a great opportunity here to mobilize our collective influences beyond what we've done already, which is already fantastic. So I just want to say that to the panel. In terms of my message to the community, as we've said before, data drives investment. Data drives improvement. And I can't say it enough. Please stand up to be counted. If you're not in the data, the improvement will not flow your way. The investment will not flow your way. And it makes our job, my job, Margaret's job, Diana's job, Ngozi's job incredibly harder because we simply don't have the basis for our argument. Please stand up and be counted at every opportunity. Thank you.
Thank you so much. Diana?
Thank you so much. Thanks once again for the opportunity. It's always a pleasure to be here. Thanks to Bola and thanks to Margaret for a wonderful panel today. Thanks to CAHN. You're doing such a great job, such a great job. And I feel so proud to be able to just even be a part and contribute, because I feel like I can do something which is of meaning, but it's all thanks to CAHN as well. You've done such a great job right from the beginning, and you're still here for the community. And of course, thanks to the wonderful audience who tune in every single week. Our community, this would not be possible without you. So thanks for engaging. Thanks for wanting to know. Thanks for being a part of this. My one message is, let's not give up. The past might be grim. The present might not be what we want it to be, and we might not be there yet. But let us not give up. Let's be positive. Let's stand up for ourselves. Let's make ourselves count, and let's change things for the next generation and generations yet unborn. Don't give up. Participate. Get involved. Get counted. Let it count for something. Let's not give up. God bless you all, and thank you to everybody.
Thank you, Diana. And Margaret?
You know, I love these. They just make me feel so warm and just lovely. So thank you to Bola. Thank you to Diana. It's been nice to meet you in this space, and I'm sure we'll connect outside of it too. Thank you, Ngozi. You've just been a champion doing this every Saturday morning. I don't know how you do it. And those that work behind the scenes, Shakina, I see you there, and Charles and everybody, thank you for putting this together. I just want to say, let's just continue to build on the power of our collective. Let's lean on each other. We don't have to do this alone. I think one of the positive things that have come out of this last year for me is this. You know, before people say to me, I didn't realise there's so many, black healthcare professionals. Where have you all been? I'm like, well, we've been here, but COVID, I guess, has brought us all out and here. So let's build on this collective and use the support to drive us forward. Thank you.
Thank you so much for your comments, and thank you also from Alice for our nutritional update that was right at the end. I've been amazed about how many Black doctors there are as well, because connecting to people, I feel really privileged to be able to connect to so many people. So, and that's what gives my energy every Saturday morning. It sets up my weekend. So I don't see it as an imposition. I actually see it as a privilege. So saying that, what have we got for May? And I'd like, for those of you that are listening in, to dial in. We've got a really, really exciting program for May. And I'm amazed about the willingness of people to give up their time to join us and do this. And I think sometimes you only have to ask. So thank you for all our panelists who have agreed or been coerced to come and speak to us in May. So we've got 2 sessions on mental health. One is how to look after mental health. And I think that's really important, especially in this, in what's happened over the last year. We're feeling a bit weary. I've had times when I've had policies, writing policies at work, overlaid with Black Lives Matter, feeling really vulnerable and just under the cosh, really. And what's helped me to keep going is being involved with organisations like this. So I've got someone coming to speak to us about what we can do to be resilient and look after our mental health, because that's important for everybody. I've also got a consultant coming to talk about sickle cell disease, because I always have lots of questions about sickle cell. So on the 8th of May, we've got sickle cell. And then I thought it was important to address dementia, because it comes in so many forms, and to be able to recognise the signs of dementia is important as well. And I think there's a lot of stigma about dementia in our community. So I've got a Black psychiatrist who specialises in old age psychiatry to talk to us about dementia and how we can help. And we've already mentioned about hypertension. I've got a consultant coming to talk to us about kidneys and your health, and that will be on the 22nd of May. And finally, for the 29th of May, I've got Dr. Robert Goddard, who's a maxillofacial surgeon, but he won the BME Health and Care Awards for Compassionate Inclusive Leadership. So he's coming to talk to us on the last weekend in May. So I'm really excited about our May programme. I've got speakers already lined up for June, but if you think of anything that you think we can talk about, just let me know. Thank you so much and have a wonderful rest of the day. Nice to see you all. Goodbye.
Well, yeah, so just to say thanks to everyone and thanks to Ngozi for hosting, but to our speakers. So we want to encourage people, please, the healthy hearts, the nutrition bit is really important. So do come along and we will update the flyer and share that. It's the same Zoom ID. So every Saturday morning is the same Zoom ID, which is great. And also, I noticed Elaine was on, but as many of you know, we decided to do some campaigning about vitamin D. So for those who live within the city of Manchester, we have some packs. We're looking for volunteers next week. So we have like 5,000 pouches of vitamin D. We want to make 3,000 packs. And those health packs will have, an African print face mask in there as well, a hand sanitizer, a pouch of vitamin D. We've been giving some for babies and pregnant women as well. And then we will also be having a resistance band to keep encouraging physical activity. So if you live within the city of Manchester, you're part of a church group or an organization, please ask them whether they've signed up to have some of those packs, for the vitamin D. And then there will be the spring wellness pack in there. So just to say thanks, everyone, keep safe, hands, face, space, and, thanks for all your support for CAHN. As has been mentioned, the Black Health Improvement Program is going really well. And yes, it can only get better, but it's all down to yourselves who give us the energy and the mandate to come in week after week, and also to our incredible health professionals, Dr. Ngozi and colleagues. We're very grateful. And to the CAHN staff team, that has grown, I don't know how many percent, 2 at the beginning of last year, over 16 now. We're recruiting for another 4 places. So check our website, there's, vacancies going, but I think there's many more great things to come. So thanks everyone. As Ngozi mentioned, if you have any ideas, if you feel there are any gaps, if you think of any ways we can improve, then let us know. But also our health professionals are available to come and talk to small intimate groups as well, and we're able to facilitate that. So please keep engaging and keep giving us your feedback. Thanks everyone. Have a wonderful weekend.
Bye.